Urodynamic evaluation of neurogenic dysfunction poses several challenges. One of the challenges is the storage phase. Is the storage safe for the upper urinary tracts? What is the precise mechanism of urinary incontinence? Is the storage pressure responsible for urinary incontinence? And does it give any prompts about the timing of intermittent catheterization? During the voiding phase, we want to know whether there is dyssynergic sphincter, whether voiding is complete, and what is the voiding detrusor function. And there are several other points which we'll discuss during our case discussion which follow. Let us start with a young man who was a soldier, aged 29 years, and he presented with urinary urgency and incontinence for the past 3 years. He also has difficulty in passing urine for all this period, and he is on external collection device, condom drain, for urinary incontinence. In the clinical profile, he had a spinal trauma about 3 years ago in the road traffic accident and sustained fracture of the body of L2 vertebra. This was followed by complete paraplegia. He underwent stabilization surgery but with no significant neurological recovery. Serum creatinine is 0.6 mg/cent. Physical examination shows neurological examination, lax anal sphincter, absent BC reflex, and perianal sensations. Neurological examination of the lower limbs show absent sensations below D10 dermatome and absent motor power in both the lower limbs. So now, the urodynamic questions in this case would be, is there neurogenic detrusor overactivity, which explains incontinence? Is there detrusor sphincter dyssynergia? How efficient is this voiding? And very importantly, is this a safe bladder for the upper tracts? So, we will now move to his urodynamic evaluation. Remember, the flow speed is extremely low to start off with. This is what we have done now, and a quick quality check is done. We start up with a filling volume. There is a low compliance bladder and the pressure rises to 30 centimeters of water at a volume of 175 ml, and there is a involuntary detrusor contraction producing leakage, another contraction, there is a series of detrusor contractions producing leakage. What I want you to give more attention to is the kind of quality of contraction as well as the leakage. Now, if you see here, there is a steady, sustained rise in detrusor pressure, but without a leakage. Why is this happening? Because detrusor is contracting over a relatively closed sphincter. Because only when the sphincter relaxes, then the flow occurs, and therefore the detrusor pressure falls. And this kind of a pattern is followed in every involuntary detrusor contraction in this case, as you see. This is a classical example of detrusor sphincter dyssynergia, because the pressure rises when the sphincter closes, and as the sphincter relaxes, the pressure falls and the leak occurs. So pressure and the detrusor flow go in the opposite direction. You may ask me, can detrusor sphincter dyssynergia be demonstrated in a storage phase of a neurogenic dysfunction? My answer to that is yes, it can be, because every involuntary detrusor contraction in a paraplegic is a nature's attempt to void, and therefore this is actually a voiding cycle as far as the nature's attempt is concerned. When it comes to actual voiding phase, you find that he cannot generate a very high voiding pressure, and there is always some amount of dyssynergia here, and therefore the flow remains low, the flow is incomplete, and the voiding is incomplete. So, in principle, he has got neurogenic detrusor overactivity as seen in the conclusion. Conclusion says the storage parameters show severe degree neurogenic detrusor overactivity, which could explain his symptoms of urgency and incontinence. However, there is also a moderate element of detrusor sphincter dyssynergia, which accounts for small volume void and intermittent flow. Detrusor compliance has reduced, as we have seen. Voiding is mostly precipitate and occurs as a part of detrusor overactivity. Detrusor contractions are poorly sustained, leading to severe voiding inefficiency and high residue. These urodynamic features are consistent with an incomplete suprasacral lesion of the spinal cord with a significant element of detrusor sphincter dyssynergia. You may add that the combination of high pressure detrusor contraction against a non-relaxing sphincter places this upper urinary tract at risk. This is an unsafe bladder requiring regular monitoring and appropriate management to prevent upper tract deterioration. Let's go to case number 2. This is a male age 82 years and he has a presenting picture of retention of urine for the past 6 days, probably a subchronic retention. He has been an indwelling catheter for all this period. Prior to retention, he had severe hesitancy, poor urinary stream, and straining to pass urine for a period of 3 years. Physical examination shows slightly lax anal sphincter. Neurological examination of lower limbs show rigidity in the lower limbs and the movements are slow. Now, he is a known Parkinson's case, which I haven't told you, but urodynamic questions here are, what is the genesis of urinary retention? Is this a neurogenic bladder dysfunction? And is there a bladder outlet obstruction? A very common problem that we are asked to resolve in the case of Parkinson's and lower urinary tract symptoms. So let's go directly to his pressure flow study. This is standard chart of pressure flow. You find intravesical pressure, rectal pressure, subtract detrusor pressure. As the flow begins at 40 ml per minute, you find that there is a mild detrusor overactivity here. There is also a loss of compliance in the form of sustained resistance, sustained rise in detrusor pressure at 154. At this point, there is a detrusor overactivity, pressure going to 48, producing leakage. There is another involuntary detrusor contraction going to 58 centimeters, producing a leakage, and there is a third one. So this is a detrusor overactivity producing leakage. Obviously, leakage is demonstrated here. The patient has a severe urge to void at the same time. Now let's come to the voiding phase. There's a lot of shake here, and that's probably because of the change in position of the patient when he goes to void. Let's expand the voiding phase, and you find that subtraction seems to be pretty good. And the voiding part, it takes a long time. This was when the permission to void was given. But at that point, patient took a long time to generate a voluntary voiding contraction. The flow began at some of this point, and the pressure flow continued for 30 to 44 centimeters of water, producing a low flow. But this does show an obstructive pressure flow pattern, but at the same time, there is a definite amount of detrusor underactivity in terms of sustenance. Going back to this case, we would say that there is certain amount of bradykinesia in these patients of Parkinson's, and this bradykinesia does not allow the flow to begin early. At the same time, bradykinesia means an incomplete relaxation of pelvic floor can also lead to a falsely obstructive flow pattern. So let's go to what the conclusion says. Conclusion says this urodynamics picture indicates a moderate degree neurogenic detrusor overactivity, which explains his presenting symptoms of urinary urgency and incontinence and reduction in bladder capacity. Detrusor compliance has slightly reduced. Pelvic floor muscles show coordinated relaxation during involuntary detrusor contractions. There is no pseudo-dyssynergia, but attempted voiding takes time to initiate. Voiding detrusor contraction is inadequate and poorly sustained, as I explained, which qualifies as detrusor underactivity. resulting in voiding inefficiency and high residue. There is no urodynamic evidence of mechanical bladder outlet obstruction. These features are consistent with early changes of suprapontinal lesions such as Parkinson's disease, where sphincter bradykinesia plays an important role in the genesis of these peculiar symptoms which these patients develop at this point of time. Meningomyelocele poses a peculiar group in our country simply because after meningomyelocele is corrected by neurosurgeons at the time of birth or immediately after birth, these patients are lost to follow-up and generally present to urologists when they are beyond puberty or at the age of marriage. This 21-year-old man was referred to us for sustained or continuous dribbling urinary incontinence, poor voiding effort, high serum creatinine, and upper tract dilatation. When we looked at his urodynamic evaluation, we found that there is a mild degree of overactivity, but more important presentation here is a poorly compliant detrusor. At the volume of 211 ml, he generates a detrusor pressure of 37 centimeters. We believe that storage pressures of 25 centimeters and above, which remains sustained, pose a severe risk to the upper urinary tracts. His leak point pressure is around 33 centimeters, but he continues to leak as the bladder fills, and then we stop filling here and we tested his voiding. If you see, there is virtually no voluntary voiding contraction here. All you see is a severe straining pattern with abdominal pressure and intravesical pressure going way high, and that is responsible for producing whatever small flow he does. This also gives you an indirect indication that when he actually does the straining effort, there is a non-relaxing external sphincter, and that's the reason why he produces a very low flow in spite of a very high intravesical and abdominal pressures. So, in conclusion, this is a meningomyelocele, which is probably a lumbosacral meningomyelocele, producing a poorly compliant bladder. This bladder is certainly an unsafe bladder for the upper tracts and explains upper tract dilatation and renal deterioration. When it comes to voiding, the voiding is at the cost of abdominal straining, is poor flow, it's incomplete, and keeps a large residue, which may also go on to explain his physical symptoms of urinary incontinence. But in this case, unsafe bladder finds the most important part of urodynamic study, and this also dictates as to if you go on CIC, what volume you should be volume. We believe 25 centimeters, so 150 ml is a critical volume for his bladder before which he must catheterize if you do not treat his bladder with either a botulinum toxin or augmentation. The last quick case in this group here is a 75-year-old gentleman, a diabetic, and has been having severe voiding LUTS for the past 5 years, getting progressively worse for the past 12 months. As you see here again, his flow, his filling remains at a very low pressure throughout filling. He has virtually no bladder sensations. If we filled his bladder to 850 ml and then we had to give him a voiding instruction simply because he had virtually no sensations of filling whatsoever. When it came to voiding, voiding permission was given at this point, but voiding started with effort of severe abdominal straining. There was some detrusor contraction, but not enough to open the outlet. The outlet opened at this point with a detrusor pressure 25. The flow remained interrupted and low. In response, detrusor contraction remained a fairly low between 32 and 25. So this is a low pressure, low flow assisted by abdominal straining. So this detrusor is not responding well enough to low flow. and therefore this is a detrusor, severe degree detrusor underactivity assisted by abdominal straining, resulting in interrupted and low flow pattern. If you go back to his history, he's a diabetic for 12 to 15 years. He's on insulin. He has been having symptoms suggestive of peripheral neuropathy. So he has a hyposensitive high capacity bladder and a low pressure, low flow state with a large residue. Goes in favor of peripheral neuropathy, principally a diabetic cystopathy.